All right, so good evening, everybody. Welcome to our joint ISSM and SLAMS webinar. We are very excited tonight to have three fantastic speakers who can talk about hypoactive sexual desire disorder in males and its implication for our couples. My name is Danielle Velez-Leitner. I'm joining you today from New Jersey in the United States, and I get the privilege to introduce the ISSM. So on the next slide, you'll see we do have the option now to add some automated subtitles, including translation. So you should be able to turn this on and off at your convenience. If you just look down on the bottom from Zoom, you can see the show captions icon. Okay, so our moderators for this webinar, myself, again, I'm Dani Velez. I'm calling from Rutgers University in New Jersey, and we have Dr. Alejandro Caraval in Colombia. Okay. So the ISSM is an international medical society. We are dedicated to the study of human sexuality, and we do that through focusing on research and clinical practice and really supporting this vision that every human being has the right to a healthy and satisfying sexual life. On the next slide, you can see our mission statement, which is to become the most respected and trusted source for information, education, and professional development in this field of human sexual health. We achieve this through the delivery of world-class publications, research findings, and then online and in-person opportunities for knowledge exchange worldwide, which is what I suspect drew all of you guys onto our webinar tonight. You can see we have many affiliated societies in keeping with our international mission. So I'm hailing in from the SMSNA based out of the Canada and the United States. And Alejandro is coming to us from SLAMS, and he'll be introducing his society shortly as well. We have several journals which are available on via print and also online. Journal of Sexual Medicine, Open Access, Sexual Medicine Reviews, and then our video journal of Sexual Medicine, which I know my residents and trainees love for trying to figure out what I'll be doing in the OR the next day. And we're really proud of our members and our reach. So I think that we've really put a lot of effort into expanding access, expanding knowledge, in trying to normalize discussion about sexual health for providers and for patients alike. This year we have up to 1,500 members for our SMSNA contribution, and I'm so happy and excited to see that that's really growing worldwide. And I'll hand it over to Alejandro to talk about our SLAMs.
Hello, everybody. Thank you for having here now just to participate with ISSM. I'm the current president of SLAMS, and this is the executive committee from the last 2 years. Next slide, please. The history of SLAMS is from 1990. Was created on Rio de Janeiro in that time, and in that conference, that congress was made in that place. Next. So our mission is to be more respected and trusted source of information, education, and professional development of sexual medicine in Latin America. It's very important for SLAMS to have that friendship with the ISSM and to support some of the many programs that have ISSM around the world. And in Latin America, there's a lot of people that is working on sexual medicine that has not contact with other kind of societies or other places to work with people that is working together on education on sexual medicine. Next. So there's a lot of things that the SLAMS expects in the future. And the most important thing is to continue to the education programs and with new leaders on the first, and to get more members that we look on the map that show Danielle maintain the high quality education level on Latin America and in the world, exchange knowledge between ISSM and the affiliate societies. That is very important to SLAMS to have contact with the other societies, and at the end to always make a stronger ourselves working within the pillars and ethics and providing the quality education of our members. Next. we had the last meeting in Sao Paulo, and last week. That was a very successful meeting. We had more than 600 attendance on the meeting, and we are very happy to have a lot of people interested on sexual medicine on Latin America. Next. We are obviously stronger together to working with all the affiliated societies and with ISSM. And it is one of the things that we are thinking for many years to have the webinars, the programs, the many activities to work with all the societies and with ISSM supporting that kind of activities.
Hi everyone, how are you? We're part of the Future Leaders programs of ISSM, and we want to take 2 minutes to invite you to be part of ISSM and SLAMS. This organization has a lot of opportunities for young professionals. First, you will have free memberships if you are in training as a resident, as a fellow, as a PhD student. Also, we have a lot of grant opportunities, travel grants, research grants, grants to participate in our world meeting each year. You will have a lot of instances for collaboration with other professionals, and you will have a lot of opportunities for networks. And another big important thing is that you will have the opportunity to collaborate with other people in research projects and in education projects. Now, Anna from Sweden is going to talk a little bit of other opportunities.
That's right, Jose. I agree on all you've said, but for me, it's also the importance of being part of the scientific journals, such as the Journal of Sexual Medicine, the Sexual Medicine Reviews, and there are others as well, but those are my favorites. And the reason for that is that I'm a psychologist, and I do think that being up to date with a biopsychosocial perspective needs us to be part of creating this together and to take part of each other's different ways of doing research and clinical work as well. So if this is you who is like us in the early career in sexual medicine, please take your time to fill out the survey. We really need your input to see how we could shape the ISSM for the future. We really hope you can do that. So thank you.
Bye-bye.
That video, that was a video from the younger people that is working with ISSM as well. I'm gonna to present the program and to start the conference. The first speaker is Dr. Leonardo Seligra. Leonardo Seligra is going to talk about the male hypoactive sexual desire disorder, testosterone and beyond. Dr. Seligra is urologist from Brazil, fellow of European Committee of Sexual Medicine, coordinator of the Sexual Medicine Group and Urology Division, FMABZ, Vice President of the Brazilian Association of Studies on Sexual Medicine, ABEMS. And Leonardo is very happy to have you here, and we are going to start with your presentation. At the end, probably we are going to have time to make some questions and answer. At the end of all the presentation, we have 3 presentations, okay?
Great. Thank you, Alejandro, for the kind of presentation. Thank you, Danielle, for moderating this webinar. And also thank you, ISSM Webinar Series, for having me to talk about this topic, because it's something I have dedicated nowadays. And gracias a todos los miembros de SLAM que están acá. Es un placer estar representando a nosotros. Vamos a tener una buena sesión ahora, ¿sí? Bueno, next. And this is my disclosures. And next, please. I always like to start every time that I discuss about sexual medicine. I like to start with these considerations about what is health. Yes, World Health Organization, that's since 1947, that said that health is not merely a absence of disease. It's a complete physical, mental, and social well-being. So we have to be concerned about this when you're doing about sexual health also. Next. Next, please. And so in this status, health status model within the biosocial psychosocial model of health, sexuality occupies a central and fundamental role, exerting significant of the individual's overall quality of life here. Sexual desire, indeed, is not a luxury, it's a fundamental part of man's overall health. Next. So it's kind to do a definition here. Sexual desire can be defined as the motivational state that may prompt individuals to seek out and engage in sexual activity. Next. And when we look after that, we see population studies show a wide variation of frequency and intensity and how often do you feel sexual desire. And here in Brazil, we had this study since from group of Carmita Abdu, and we saw here that many of men can say that sometimes in a month he's often to feel sexual desire, and it's physiological. It's not a pathological way. But when the reduction is persistent and clinically significant, distressing, and we move to a pathological way, then we have low sexual desire, and it signs to 12% of the ones men here in Brazil. Next, please. And we should pay attention that the male sexual response is an important thing to discuss here because it's often mistakenly reduced to the concept of erectile dysfunction or erectile function alone, and as if it was only an on-off switch. Next. And we know that in reality, the sexual response is considered much more complex. It's comprising the initial phase of the arousal, followed by erection, and then resolution in a latency period, as said by Masters and Johnson once ago. But this process is modulated by a wide range of factors, both intrinsic, extrinsic, as well individual's personality, and also prior sexual experiences. Next. And also we can see here that we have a lot of bunch of neuroendocrine and psychosocial symphony. In the brain, sexual stimuli activate reward regions, bolder sensation process, attention, visual processing, and it's more intensive in men, and we can see in red here, than is intense in women, that is in blue. And also neurochemically, dopamine, catecholamines, testosterone, kisspeptine would rise or accelerate sexual desire, while serotonin, opioids, and histamine could act as a brake. We have in the middle endocannabinoids receptors also find this balance, but it's something we can discuss later. Next, please. When we talk about the definition in hypoactive sexual desire disorder, we have this brand new definition of DSM-5 that is a persistently or recurrent deficient or absent sexual fantasies and desire, and it's obvious causing distress. It has a period that we have to be awareness that's more than 6 months and should be independent or not clinical sequela of any other mental disorder or any other relationship distress, and it's not attributed to the effects of substances or medication. However, in clinical practice, we have many men that go unnoticed because symptoms could be confounded as erectile or ejaculatory dysfunction and is dominate the initial complaint. Next, please. We have here overall the word that low sexual desire is up to 14 to 17 in most here in America, young men, but it's increasing with older age, increasing with the presence of depression, and even with poor health like diabetes and metabolic syndrome. We can also see women suffers more with low desire than men, and we can see also that premature ejaculation and erectile dysfunction are more prevalent in men. Next. What's the key differential diagnosis we need to consider here? Men presenting with low libido, we have to have the evaluation of hormonal levels, particularly low testosterone and elevated prolactin when we should suspect of prolactinoma. In addition, both low and high estradiol may play as a role in the symptoms to relate sexual desire in men, even with an use in some medication. Once clinicals are excluded, we most carefully explore mental health, such as depression, anxiety. We can act as both causes of consequences of reduced libido. We have to distinguish, as I said before, complaints of other sexual dysfunctions, exclude erectile dysfunction, exclude premature ejaculation. This condition may overlap and confuse when you are seeing a problem. We also have to say that in initial stage, psychological and social aspects are including mood, relationship dynamics, religious beliefs are also important and we need to take in account. And we live to understand that could an individual experience may play a role. And finally, but not less important, we have to say about medications, because we have a lot of medications or drugs or other substances abuse can negatively affect libido. So next, please. First of all, we cannot talk about hyposexual disorder without acknowledging that depression, anxiety, relationship conflicts, even issues of sexual and gender identity can have a huge impact in libido. Low libido can be the first symptom of depression in men, and ignoring this, we can miss a chance for early diagnosis of this condition. Next. Next, please. We see that mood disorder strongly is associated with folding 3 times emotional problems, anxiety, depression, stress. And as I said, low libido is an early indicator of depression. Next. Next, please. I would like to highlight here hypogonadism is an important diagnostic differential, but I would highlight here functional hypogonadism because comorbidities as obesity, metabolic syndrome may contribute more than other stuff like age or even elderly men. And among biological cases, this is a condition that we have compromised libido, and we also have to see any other stuff like the next slide. And we can show here that some studies show that each additional gain in body main unity reduces testosterone about 6 nanogram, and each hour of lost sleep costs another 5 nanograms. So we have to look after sleep disorders, we have to look after obesity more often than age when you're talking about low testosterone. Next. When you talk about other hormones here, and I show you the estradiol relationship with any other conditions here of sexual dysfunction, it may be associated with erectile dysfunction, premature ejaculation, and other libido. Next, please. And also when we talk about hyperprolactinemia, we have a high prevalence of hypoactive desire, but also less sexual intercourse, less nocturnal erections, is in its high association with hypogonadism and hypothyroidism, and we have to look after thyroid problems when we are looking after low libido also. Next. And when we're talking about medications and we have to isolate them to diagnose hyposexual disorder, the most compromising is the antidepressants, and we are talking about the inhibitor selectors of serotonin. And also we be concerned about when we are getting off these medications and these persistent symptoms can be. But as urologist, I have to highlight these 2 medications and that we use for treat low testosterone in some kinds of circumstances. There is clomiphene and anastrozole. They will modulate estrogen receptors, and as we said, estradiol highs or in low levels can also introduce low libido symptoms in men. Next, please. So when we concerned about all this treatment requires a multifactorial approach and identify and treat reversible causes as endocrine disorders, review medications is important. But we'll have now both good discussions with Silvina and Lori about psychological intervention, about couple focused care, because it's impacted bi-directional. The partner with a low desire both affects and each other affects each other. So we have to give a multifactorial approach. And as urologists here, we can improve this treating endocrine problems like testosterone, estradiol, or thyroids. Next one, please. The only approved, no, or can I say the only very studied treatment with medications about low libido is the testosterone replacement. And here we can have the Traverse study. that received the testosterone and compared to placebo at 12 months, and testosterone group showed significant gains in libido scores and symptom improved. But I'd like to reinforce here that it's only when indicated testosterone therapy is effective and clinically meaningful. Next. However, and sorry about this unconfigured here the graphics, we don't have any improvement in erectile function. However, it has a libido improvement. We don't have an improvement in erectile function. And next, please. So we have to be aware that we are treating a man with multiple disorders, sexual dysfunction. We can, or should and must treat it conjunctly. And in this case, erectile function could be treated with an inhibitor of APD5. Next one, please. And so as take-home message and to take to my partners in this webinar, I could introduce that hyposexual disorder has multi-factor etiologies. Other sexual dysfunctions contribute to underdiagnosis, so we have to look after erectile dysfunction, premature ejaculation, and treat it before diagnosing. Identify biological disorders is important, and most of the men will have to be in testosterone serum evaluate, and TRT in hypogonadal is really good and had meaningful clinical improvements. And also, as I said, multidisciplinary approach is very important, and is that why we discussing here. And after we could be able to do some Q&A, and I'll be pleased to take your questions. So thanks for your attention, and I'll pass for the next presentation. Thank you very much.
Thank you, Leonardo. That's a very good, interesting topic, and I think everybody has patients that receive on the office talking about that topic. That it's very important to have some support with the studies, with a lot of data that you told us in your presentation. So I'm gonna just present the next speaker is Dr. Silvina Valente. Dr. Silvina is an Argentine physician, specialist in gynecology and clinical sexology, president of the Argentine Society of Human Sexuality, and head of the sexual health program of the Hospital de Clínicas University of Buenos Aires. Dr. Valente is a member of the Executive Committee on the Latin American Society for Sexual Medicine, SLAMS, and he's the Vice President of the Latin American Federation of Sexology and Sexual Education, FLASES. Dr. Silvina is going to talk about the couple response to low libido in men with HSDD. Please, Silvina, you can start now. Thank you for the participation.
No, thank you for the presentation, Alejandro. And for me, it's an honor to participate in this webinar, and I appreciate the invitation of SLAM and ISSM. On this occasion, I will speak about the couple of the man with low desire. So we are going to the next one. I would like to debunk some socially constructed myths about men and reflect on how these can lead to communication failures and difficulty in managing their emotions. Therefore, I would like to emphasize that men, like any other human being, have right to feel shame about low sexual desire. It's valid and understandable. Also, they have permission to express it, because silence does not protect them, instead leaves space for negative interpretations in their partners. Next, please. And what about silence? When there is no communication, the partner may interpret, I'm not attractive, he doesn't desire me, he doesn't love me, he doesn't value me enough. These interpretations are filled with emotional content and create disconnection and distance. That is why the role of communication in couple is important, as expressing emotions and concern reduces the emotional burden, allows for joint problem solving and promote intimacy and validations. Good communication strengthens the couple's bond. Therefore, in line with what has been stated, a good message to convey to men who experience low desires and feel bad about it is that they should not see this as a weakness, and that effective communication is the gateway to being understood, supported, and building new forms of intimacy. Shared emotional management is a key to sexual satisfaction and couple well-being. The next, please. But for men, even today, communications remains a challenge. Several studies have shown that sexually dysfunctional couples report communication problems. Couples often avoid having discussions about sex and their daily lives, as they evoke strong negative emotions such as anxiety, fear, shame, guilt, which generally manifest as anger and emotional escalation in an attempt to hide the shame that they feel about not performing well sexually and the sense of responsibility for not being better at sex. The increases pressure arguments, distance, and silence creates misunderstandings between partners and avoid an opportunity for dialogue and understanding. In the end, it drives them apart and makes both feel bad. The next, please. But we know from published statistics that persistent low desire with associating distress is one of the most common sexual complaints, as Leonardo talked to us, in men and affects their sexual and relationship well-being. Many men with low desires do not seek medical advice. Partners are often the first to notice the problem and sometimes the ones who seek help. Low desires impact the couple. It decreases sexual and relational satisfaction, increases sexual discomfort, and generates conflict, feeling being unwanted and emotional distress. The next, please. The etiology is complex and multidimensional, but the biological causes, such as variation in testosterone and levels and the effects of anti-androgen therapies, are better studied, as are the personal psychological causes, including anxiety and performance anxiety, which are among the most researched symptoms with male sexuality. Although it is known that interrelational or partner relation factors, particularly in long-term relationships, influence the manifestation and maintenance of these conditions, deteriorating sexual, personal, and relational well-being. Moreover, given these characteristics and the fact that men may present with erectile dysfunction, depression, or stress-related symptoms, it's important for urologists and psychiatrists to recognize that a couple consultation is essential, just as gynecology should consider when a woman presents with low spontaneous desire that she may be partnered with a man who also has low desire. Although many times they blame themselves for not having spontaneous desire and worry that not seeking their partner sexually might be the reason for their partner's sexual disinterest and distancing. We must be attentive during consultation, as the state complaint is not always the real reason for the visit. The next, please. I would like to highlight that male low sexual desire affects both individuals and partners' sexual well-being. Yet, interpersonal aspects remain unexplored compared to biological and personal factors. The next, please. This study I bring, conducted by Wand and colleagues, is the first dyadic study to date with men with low desire and their partners. They investigate the emotion regulation strategies of 64 couples, studied and observed that those who use emotional suppression strategies have lowered sexual assertiveness, poor sexual relationships, and poor communication, and their partners were also less sexual assertive. On the other hand, those who are able to reappraise or reassess emotional difficult situation were more sexually assertive, and by being able to talk about what was happening to them, they received greater support and their partners did not experience as much sexual dissatisfaction. The next, please. The final conclusion of this study was facilitative response improved satisfactions in both. Negative response decreased sexual satisfaction, and avoidant response do not directly affect sexual satisfaction, but increase the partner's sexual distress. Facilitative response to self-perceived low sexual desires do not improve the partner's sexual satisfaction, but they also do not cause distress. In contrast, negative response to own sexual desire reduce sexual satisfaction for both. In clinical practice, many women seek consultation because they believe they should initiate more sexual activity so that their partner will be less irritable or depressed, or to rekindle the connection. Based on these findings, we should consider whether we might be dealing with a hypogonadal man with limited emotional regulation resources and avoidant behaviors. For this reason, it's essential to invite both partners and assess the relationship function as a couple. It is common for women to feel guilt and distress due to the low frequency of sexual activity. It is also to be expected that they may overlook the possibility that is the man who lacks desires, who fears being unable to achieve an erection, and who does not know how to communicate this to his partners, especially since, due to social expectation, he's supposed to always feel desire and be ready to have sex. This is another couple study evaluate the association between sexual motivation and intimacy, satisfaction, and distress in men with low desires and their partners. Naturally, those who had sex for the pleasure itself rather than the mere obligation of obtaining an external reward show better satisfaction and well-being parameters and less distress. Therefore, the conclusion is promoting automated sexual motivation may improve intimacy, satisfaction, and reduce distress in these couples. The next, please. Therefore, the interpersonal emotion regulation model proposed by Rosen and Bergeron, applied to the treatment of hypoactive sexual desire in women, is also suitable for addressing low desire in men and their relationship. This is because the way sexual difficulties are managed with a sexual partner can be communicative and assertive, facilitative or alternative, negative and hostile, with poor management of shame and emotional defensive response to criticism, creating emotional distance or solicitude yet avoidant. These different ways of handling difficult sexual situations radically change its impact and result in distress, leading either to share problems to be resolved together in connection, or distancing and disconnecting them, whether through anger or emotional emptiness. The next, please. Therefore, successful regulation will foster the adequate communication. This is why it is important to strengthen open and positive communication through behavioral and emotional techniques. The next. It's important to replace maladaptive strategies with adaptive ones. The next, please. Through cognitive reeducation to interpret emotional negative situations into more positive ones, identify the emotional distance created by poor communication between both partners, an attempt to reduce the distance and conflict by improved assertiveness and sexual satisfaction, that fostering intimacy in the couples. The next, please. Another important point in couple therapy is to make sexual script more flexible, as this can improve the couple's well-being, strengthening caress and reducing the pressure to have intercourse, as the only sexual activity can help them to connect with it without pressures. The next, please. Other factors relate to low desire associated with male hypogonadism, including sleep apnea and snoring. This condition can reduce women's sleep quality, which is, as noted in the 2023 sleep meta-analysis, increased the prevalence of sexual dysfunction, not only in men, but also in women. Reduced sleep quality and shorter night sleep duration in women are linked to higher sexual dysfunction risk. The next, please. Another point to take into account is the concept of double pause proposed, evaluating the couple of older adults as a unit, and consider sexual health important in addressing well-being during aging. It addressed the sexual problems of one member of the couple or both as a unit, while at the same time recognizing the alteration in health having implications for sexual health. Sexual health is considered a key pillar of quality of life. So this article proposed addressing the couple as a unit, and in this topic, which has been so often neglected by general practitioners. The next, please. In other words, sex is often a learning process. Losing sexual skills immerses us in fears, insecurity, and shame, which lead us to avoid not only sexual activity with our partner, but also our partner themselves, and to avoid affectionate situations altogether out of fear of not performing. It is important to realign goals, work or mutual understanding, and rebuild emotional connection between both partners. The next, please. Another topic is the age asymmetry within the couple, where other associated issues may arise, such as infertility and sexual demands, often accompanied by significant frustration on the part of a man. The next, please, and for conclusion, the end, that it is a complex issue that requires further research, but is essential for professionals dedicated to sexual medicine to view it as a whole and work on an interdisciplinary approach, addressing not only the individual's biological and psychological aspect, but also the couple as a unit. Better emotion regulation and supportive partner response might improve communication and attachment in the couple facing low desire for men. Thank you.
Thank you, Silvana. Very nice presentation. I'm going to let Danielle introduce the next speaker.
Thank you. So our next speaker is Dr. Lori Brotto. She is an internationally recognized as a leader in sexual health research. She has mentored over 180 trainees and evaluated psychological interventions for sexual dysfunction and genital pain, which collectively impacts 1/3 of women. Her work influences practice internationally, with mindfulness now implemented in sexual medicine centers and is recommended as frontline care and for international guidelines. In recognition of her contributions, she holds a Canada Research Chair in Women's Sexual Health, and she's also received recent awards in mentoring junior faculty through public education, through media, book awards, and she's listed among some of our top cited scientists by Stanford and Elsevier. So we're very excited to have her speak tonight about her mindfulness techniques.
Thank you so much, Danielle, and thank you to ISSM and SLAMS for putting this Really wonderful conversation together. And Leonardo and Silvina, I loved your talks and was furiously taking notes throughout. So happy to be here today. For those of you who might be familiar with my work, you'll probably recognize me as most of my research has focused on women's sexual health and sexual problems. But don't worry, I'm going to say something about men's desire and men's sexuality closer to the end of this talk. Next slide. So just in terms of disclosures, I do want to disclose that I have written a couple of books on mindfulness and sexual health, and I do derive royalties as a result of that. Next slide. And so my goals today are really, for those of you who may not be familiar with mindfulness-based approaches, I think Leonardo did an excellent job of making the case for a biopsychosocial approach in managing low desire among all genders. And certainly Silvina went into a lot more excellent detail about kind of underlying theoretical theories that really support that approach. So I'm going to go even more focused and focus specifically on mindfulness as one psychological tool that that you can use. I'll share some of our data on women, some on men, and then I really want to talk a bit about mediators so that you can understand as a healthcare provider, how do these treatments work? And I know certainly when I propose mindfulness as a treatment to my own patients, sometimes it's met with skepticism. Sometimes patients will say, so you're telling me that breathing and paying attention to my body will improve my desire and arousal? And so I think understanding the science behind that so that you can communicate these to your patients can be really useful. Next. So Leonardo did an excellent job talking about prevalence. Next. And some of the data that I draw heavily from are from NatSol, the third wave. Of course, we're waiting for the fourth wave to be published. But we do know that among the different concerns expressed by women, that low desire is certainly the most common, with up to a third of women across ages, across geographic locations, across menopause stage, will report low sexual desire. And interestingly, many of the large population-based studies similarly find low desire to be the most prevalent of sexual concerns in men, although we tend to talk much more about erections than we do about low desire in men. Next. So why a mindfulness-based approach? And this cartoon image, I think, nicely depicts, in some ways, the modern day woman who works full-time. We might refer to her as being in the sandwich generation, where she's caring for kids and elderly parents with needs at the same time. There's a lot of emphasis now on longevity and aging well and health promotion. And so along with that comes exercise, volunteering in the community, balancing all of that, of course, with extracurricular activities. And while at the surface, this appears like something we all strive for, we all want this balance. In reality, what we see is that this can take quite a cognitive toll and as well as emotional toll. And when you factor in the impact of technology, where with our smartphones and other devices, we can immediately be pulled out of the present moment and tend to work calls and be on the other side of the world in a moment's notice, it does mean that our minds, our brains become very, very good at being everywhere but the present moment. And so, next slide, when we interview couples and we ask them to think back to a sexual encounter through their life that they defined as being optimal, excellent, and we say, what made it so? And this is some of the excellent work done by Peggy Kleinplatz at the University of Ottawa in Canada. And what these couples will usually always describe is a moment of presence, being totally in sync with a partner, nothing else matters, hyper-focusing on their and their partner's sensations. In other words, it's a moment of mindfulness. Next. So how do we define mindfulness? And researchers around the world have come together, and they've defined it as non-judgmental, present-centered awareness, next, in which each thought, feeling, or sensation that arises is just acknowledged and accepted as it is. So mindfulness is about two things. It's about paying attention on purpose and also doing so non-judgmentally and compassionately. And it's that combination that makes mindfulness unique from other attention regulating strategies. It makes it very different from hypnosis or visualization. And given its secular nature, it's also different than traditional Buddhist meditation practices. And because of that, it's certainly accessible to everyone, regardless of your religious affiliation or not. Next slide. And some have described this in really accessible ways. I love how Deepak Chopra, well-known meditation practitioner and writer, who says, as you turn unconscious eating into awareness eating, the next stage, awareness living, isn't far behind. And I put the image of a raisin on the slide because in the groups that we run, whether they're in person or online, we always start with an opening eating meditation with a raisin. And the person is guided to observe the raisin, hold it in their hand, hold it up to their ear, smell it, place it on the tongue, take one bite of it, experience the explosion of flavors, and all of this takes place over 10 minutes. So it can be a very vibrant taste, if you will, of what mindfulness is. So over the last 20 years, my lab has been very focused on developing and adapting mindfulness-based interventions to different populations of mostly women. And I'm going to share just a slice of the data. And then, like I said, we'll talk a little bit about its applications to men as well. Next slide. So by way of background, in developing our current intervention, which is an 8-session intervention targeting low desire in women, next, we started out by doing a series of pilot studies. So first we offered it in a monthly format, and the initial work I did when I was a fellow at the University of Washington, which was with cancer survivors with sexual problems and mostly low desire, it was designed to be a monthly intervention. And so it mapped onto when patients were coming back for their monthly visits with their oncologist. So they would see their oncologist, and then I would meet with them and do a mindfulness session. And then we put together a little program designed to help gynecologic cancer survivors be more in touch with their sexual sensations. And it worked. So we've tested this in a monthly format, 3 sessions, and we expanded it to 4 sessions or over biweekly. And then all the way along, we gathered a lot of patient feedback around what their preferences were, and they really wanted more. They felt that at the end of 4 sessions, they were just getting going on their practice, and they really wanted to take a deeper dive. So very consistent with mindfulness-based stress reduction or mindfulness-based cognitive therapy programs, which are extremely well empirically supported for depression, anxiety, and a host of other issues. We followed a similar format in our implementation to women with low desire. Next. And so after a series of pilot studies, we were able to get some funding from the Canadian Institutes of Health Research to run a randomized clinical trial where women who were diagnosed, we used the DSM-5 criteria of sexual interest arousal disorder, but it essentially captures those women with hypoactive sexual desire disorder. They attended weekly sessions for 8 weeks, and then we followed them at post-treatment 6 months and 12 months. And we compared that to a sex education control group, which had no elements of mindfulness or cognitive behavioral therapy. It was just giving them educational information in a supportive environment. Next slide. And so you can see the breakdown in the consort diagram here. We started with about 150 women who are randomized to group. And then at every assessment point, they filled out questionnaires. They also came into the lab to do some sexual psychophysiology testing. We measured interoceptive awareness, which is our ability to sense what's happening in the body. We looked at heart rate variability. We collected cortisol samples to look at diurnal cortisol response. And then, of course, a battery of questionnaire. Next slide. So just a taste of what we actually did in the intervention. So in every 2-hour session, the first hour of it was dedicated to a mindfulness practice. So we didn't just rely on people to go home and practice on their own. We did the practice together in session. And so over the course of the 8 weeks, we built on foundational mindfulness skills and then progressively moved them into the sexual scenario. So as women maybe observe their own body, as they engaged in self-touch, and then progressively as they engaged in sexual activity with a partner. Next. We also had an exercise, and we've actually published on this one mindfulness exercise separately, where we had women first engage with a sexual tool. So either a vibrator, erotica, or fantasy to elicit some arousal, and then they did the mindfulness practice. And if anyone wants to read that publication, it's a fascinating paper, and we found that even a single session of mindfulness can significantly elicit both subjective and physiological arousal. Next slide. We had very high engagement. So the vast majority of participants attended the groups, and there was a lot of engagement with the homework. So after every session, we would send them home, and they would do between 10 minutes and 30 minutes of mindfulness practice every day. So what did we find next? And on the series of slides that follow, I'm going to show you the psychoeducation group on the left and the mindfulness group on the right. And you can see that in terms of sexual desire and arousal, we use the CITI to measure this. There was a significant and very clinically significant improvement in sexual desire. There also was in the psychoeducation group. Next. In terms of distress, we saw a very significant and clinically meaningful drop in sex-related distress. Next. And then similarly, a decrease in rumination. And rumination is the tendency to worry about performance or worry about a sexual outcome, which a lot of our patients with low desire will report. And we saw that the mindfulness group was more effective at reducing that than the education group. Next. And then in terms of the mediators, so what are some of those underlying mechanisms that explain how mindfulness works to improve low desire? What we found in the mindfulness group, and that's the image on the right, is that improvements in self-compassion, improvements in interoceptive awareness, reductions in self-criticism, improvements in their ability to be mindful, and reductions in depression accounted for those improvements in desire. So as we explain this to patients, we can say, we actually understand the mechanisms by which mindfulness will improve your low desire, and here are some of them. Keep in mind these data are on women, and so I would love a collaboration if anyone would like to test this in men to see if these are some of the same mediators at play. Next. Actually, one more next after that, because I want to talk a little bit about some of our application to men. And so what we've done in a partnership with our colleagues in urology is we've adapted this intervention to prostate cancer survivors and their partners. And our urology colleagues have shared with us, some of their own frustrations around the limitations of the PDE5 inhibitors, and recognizing the importance of including mindfulness and other psychosocial strategies in their care. So here's what we did. Next slide. We randomized couples, so prostate cancer survivors and their partners, to either a control group, a 4-session cognitive behavioral therapy group, or a 4-session mindfulness group. And then we followed them over time to 6 months. Next slide. And I'll ask you just to forward through the next slide. So what did we do in the mindfulness groups? Very similar to what we did in the mindfulness sessions for women, but we condensed it down to 4 sessions because we weren't sure how feasible it would be to deliver 8 sessions of mindfulness to these prostate cancer survivors, some of them who had brain fog associated with chemotherapy. We thought, let's start with a 4-session intervention and see if we have some feasibility and proof of concept data here. And we have treatment manuals that explain the components of these treatments as well. Next. So a snapshot of our couples. The survivors were on average 68 years old. Most were heterosexual and white. Almost all were retired. And only 4 couples had active surveillance instead of treatment. Next slide. What we found is that both CBT and mindfulness led to reduced distress, and that was our main outcome, was sex-related distress from baseline to 6 months. However, the mindfulness group had an even greater decline in sex distress than the CBT group. So both are effective, but some evidence that mindfulness is even more effective. And what we found, next slide, was that the role of the partner in this intervention was really quite important. And we followed it up with some semi-structured interviews, and the partners in particular, most of whom were women, though not all, said that the inclusion of sensate focus allowed the partner to really feel like they could play a role in the survivor's recovery or development of their sexual wellness after that. Next slide. So the last thing I want to tell you about, oh, one more slide after that, is just some of the work we're doing right now. And we've created a digital health tool called eSense, and it's because there's lots of barriers in our patients accessing people like me or my colleagues who are sex therapists. And there can be lots of barriers regarding stigma, cost, distance, embarrassment, etc. Next slide. So as we are seeing this explosion of digital health tools, we put together eSense, which delivers mindfulness-based therapy and cognitive behavioral therapy to women with low desire. And since about 2016, we've worked together with patients to design the entire portal, create all the videos, create downloadable meditation files, and we've tested this in a large series of studies over the years since then. Next. And the stage that we're at right now is, you can see some of the schematic drawings, which were done by patients that we collaborate with. Next. And the stage that we're at right now is trying to export and scale up and make eSense available. Next slide. So if anyone is interested in perhaps testing eSense in your own clinics, we're about to start a commercial pilot. And so you can look at that URL in the top left corner of the slide that just went past and feel free to get in touch with me. And so look forward to opening it up to the group now and having our Q&A session. Thank you so much.
Thank you. Thank you, Dr. Lori. It was a very interesting topic. And to be honest, I don't have experience on the past to look that very, very interesting. I know that there's a lot of people interested now just to know more about that kind of therapy that you can offer for their very, very common symptom that we are receiving, like a urologist or sexual medicine doctors. So we have just some time to some questions. I have one question here on the Q&A, and I'm gonna make that question probably to Silvina. The first question is, assuming that baseline physical attraction to the partner is a prerequisite when discussing low desire, is any gender?
Oh, no, I don't think it's a prerequisite to have physical attractive. I think it's a couple of long-term have a lot of spiritual attractive, sense attractive, and a lot of and they build their identity as a partner. So perhaps it's not the physical attraction the most important in a long-term couple. I think they are more attractive in souls and spirit and in love. So I think that it's much more important. That's why it's important to flexible the sexuality here in this couple.
Daniel, I don't know how many time we have to questions, but
Yeah, no, I love this next question from Chen. This one's directed towards Dr. Brato. So for individuals being highly anxious, easily distracted, or in pain, how do you successfully implement mindfulness? And that was what was going through my head a lot as everyone was talking, actually, is, I see a lot of cancer survivors in urology, and sometimes I can't even get to the point of asking about genital pain or erectile function or orgasm because they can't even get past their low libido.
Yeah, great.
And how do you sort of be anxious, or the person who's like just can't even begin to talk about it?
Yeah.
How do you guide them through?
Yeah, I'm going to give the data question first, and Danielle, I'm going to answer your question on how do you talk about it. So we've published a number of studies and RCTs using our mindfulness interventions, specifically among women with a diagnosis of provoked vestibulodynia or vulvodynia. And that really draws from the larger literature showing mindfulness to be highly effective in management of chronic pain. So of course, how you describe mindfulness is really important, because if you were to tell any individual, let's say a person with chronic pain, just breathe and pay attention and your pain will get better. They might perceive that as you dismissing them, right? So you're just telling me my pain is all in my head and I just need to breathe and it's all okay. What are you saying? So in particular with those folks with pain is I will often show a diagram of, central sensitization and the fact that all chronic pains are maintained from brain mechanisms. And so often, we focus on the site of the pain, right? We focus on the vulva and vagina and there's nothing there. And then of course, patients feel very dismissed. So I always refer to the neuroimaging literature, which has proven time and time again. And I use that word carefully because I don't like to use the word proven, but it's been shown so many times that repeated mindfulness practice changes the brain structurally and functionally. So that's how I would address the pain part. And then Danielle, to the first part of your question is like, how do you even broach this with a patient? And I would say I start in small doses. So even in our work with prostate cancer survivors, we've done this a lot with men with situational erectile dysfunction as well, is we say, look, you've tried 10 other treatments. They haven't worked to your liking. You have nothing to lose. Why don't we try a small dose of this? And I'll literally do a 3-minute meditation with them in my office just to give them a sense of what it feels like. And then we'll build from there. The mindfulness is especially effective for the highly anxious and easily distracted people, because those are the folks that in the sexual scenario, they're more prone to negative sexual thoughts, they're more prone to spectatoring, they're more prone to negative self-judgments. And if you read Pedro Nobre's work out of Portugal, he's published countless studies that show the impact of distraction and negative thoughts directly on sexual function in men and women.
I think, Danielle, because as urologists here, we have a bias also because we are ISSM, SLAMS, and SMSNA, and we are like to embrace the patient as well in our consultation. But it's not the common way that urologists that are not allowed with sexual medicine that do this. So this is our biggest concern, to embrace the patient and to give the options for him, because when I say a failure of treating him with testosterone or a failure using without medications, we have to show the way, show the pathway, and get together this multifactorial, and that's a big concern yet. So that's why we have to give him the right way to go.
There's another question here that is very interesting. I think it's for Dr. Laurie or anybody what can respond. Is about artificial intelligence, probably the use and that I don't know if probably in mindfulness or the physical or the sexual therapy for Silvina or for Leonardo have some tools to work with the intelligence, artificial intelligence.
Yeah, happy to jump in. And I definitely want to invite my colleagues. So Laura Vowles, who's at the UK, has published a large number of studies where she has compared specifically women with low desire who are seeing a human sex therapist versus an AI chatbot. Guess what they found? Almost no difference. So it communicates to us that when people feel validated, when they're given an environment where they can be honest and not judged, that it is highly therapeutic for them. So I highly recommend looking up the work of Laura Vowles. In our own work, I mentioned our app, eSense. We have an AI tool built into it as well, where the role of the AI chatbot is just to give some moral support and validate the users of eSense. It's not giving any therapy, but what we're seeing in our research is that it results in a lot of engagement with the digital health tool. And people are very open to interacting with an AI chatbot.
But I think we need to pay attention of that, because some artificial intelligence machines still hallucinate with some answers. And maybe if people go to do treatment with AI, we'll have some problems, because once we have the SLAMS meeting this evening, and just 2 days ago, and we have a beautiful talk there and say, oh, where is the biggest bridge you have, the tallest bridge you have here I can jump? Oh, the next bridge just 2 squares around, and then okay, I'll go there. So we have to pay attention that AUI may hallucinate it and incentivate some behaviors that are not so good. So we have
Yeah.
still to do something about that.
I agree.
It looks
There-
like, oh, go ahead.
Danielle, you,
Sure, I was
please
gonna
go
say
ahead.
that it looks like you've got another great question. What is the management of hypoactive sexual desire in men when organic or functional causes have been ruled out? I know in my practice, just as Leonardo described, like there's a lot of baseline blood work and kind of ruling all those things out. But again, like in the cancer setting, we have a lot of men with metastatic prostate cancer. They're on ADT. I know that their T is lower than mine is. So then when you move beyond that, how do you guys typically manage?
Yes. And also we have to do this practice about confounding erectile dysfunction and premature ejaculation that is also confoundable for the patient. And to do this differentiation is very important to really know what is biological or not about desire. Yeah.
Leonardo, I have one question for you. That is a very common question here in Colombia. There's a lot of people, there's a lot of doctors treating that problem with the testosterone replacement therapy. So, but all the people is asking, what is the time that you can wait just to have some results or some changes of the desire of men?
It's a really important question because most of people who treat with testosterone replacement ask for a rapidly response. And patients urge to immediately respond about desire, but it's not what we see in the practice. We have to wait at least 3 to 6 months to see a response, well response about libido. And we are talking about erectile dysfunction. It may be at least a year, maybe. So we have to take time to testosterone replacement, do the work, do the job. And then after that, we can do, okay, the testosterone is not working for this man, and we have to change of our treatment, but at least 3 to 6 months.
I wonder, has anyone used anything like the Vyleesi or the Addies? I can't remember the
I have
generic.
seen so per papers about this in men. I have seen it in women, but in men, I haven't seen any job about that. Have you seen, Laurie, something about using medication in this population as you use in human?
In men, I have not seen any published
Yeah,
studies.
neither.
I mean, I know the early studies on flibanserin were both in men and women, but they saw a much greater response in women. I'm sure folks are experimenting with it clinically. That'd be a great question to put out to all the societies and do a case study on is, has there been any success with these products in men with low desire?
They're here on a very interesting question, discussing HSDD. Is different for the heterosexual long-term partners? How much does the psychosocial aspects of the HSDD in gay men do you include in your therapeutic approach, Silvina?
Well, I don't have read any study of gay men in low sexual desire partners, or so partners of gay men. I suppose, I don't know. It's a topic that it's not well studied in the couples heterosexual. So I think it's a doubt that we have to study that gay men's. I don't know. I don't read anybody. I have patients case with low sexual desires, one and the other no, but it's not the same that heterosexual partners because but it's not too many. I have 2 or 3 couples of gay men here in Argentina treated by low desires, but no, I don't found any study about it.
Laurie, do you have any comment about?
Yeah, I mean, I'll take the second half of the question because I think Silvina did a good job with the first part. And it's, how much does the psychosocial aspect of low desire in gay men, is it relevant? And it absolutely is. So among gay men, we know that there's a higher likelihood of consensual non-monogamies, right? So having additional sexual partners which not surprisingly can do wonders for low desire. And that's less common among heterosexual couples. So definitely the psychosocial part is really, really important.
Laurie, and there's another question that mindfulness session with facilitators, how often has shown the best response?
How often has, meaning like how many sessions shows the best response? Do you think
Yeah,
that's what they're asking?
Yeah, sounds like this is just a short question.
Okay, I'm going to assume it means how many sessions. Yeah. So we have found 8 really strikes that balance between what's feasible, meaning not too many and not too few, and maximal effectiveness. And one of the things I didn't really highlight when I showed, my graphs, but also now in a number of studies, when we reassess women a year later, so this is 12 months after they stop the program, none of their improvements have been lost. So if anything, their desire and distress scores continue to improve over time. Now, why is that? How can an intervention they did a year before have this impact? And it's because they're quite motivated to keep practicing, because they're noticing not only these benefits to their sexual health, but they're managing anxiety better, they're managing stress better, they're sleeping better. Lots of evidence for mindfulness in managing hot flashes and menopausal symptoms, which is my new favorite topic. And so, I think that's where some of the real value in mindfulness practice. Yes, it's a big investment of time up front, especially when you talk about an hour a week for 8 weeks, but the long-term impacts are quite sustaining.
Okay, I think I will need to close the session, but I would like to have the last comments. Probably I'm going to start with Leonardo just to close the program.
Yeah. First of all, thanks for everybody for being here with us. It was a good session with Laurie, Silvina, Danielle, and you, Alejandro, and all the people here with Q&A. I think the most important thing here is to quite open to work together with psychology, with gynecology, and neurologists, because when you are concerning about biopsychosocial aspects, is much more than only to biological treating hormone or treating erectile dysfunction. And as I said, we had to embrace these patients and see that they have more than pathways, only not treating only with medication, but also with psychotherapy or mindfulness. And men are not so open for that than women, and then we have to teach them and to educate them that this is a good approach and we will have good results. After all, we have a men that will get a good quality of life after that. So thank everybody, and I think it was very, very great. Thank you.
Thank you, Leonardo. Silvina, the last comment.
Well, thank you, everybody. Thank you, Leonardo. Thank you, Laurie. Thank you, Alejandro. And thank you, Danielle. It's a pleasure to hear you, both of you, in this session. I think that I want to result the interdisciplinary work is very important here in sexuality. It's very important to see that perhaps if you are not in couple, but you have to have sex with another people. And this is the problem of low desires in men and in women, because they don't want to have sex with another people. If they don't have to be in a relation, in a relation, they don't have to have desire. It's not a problem. When you are in a relation, the low desire is a problem. So don't forget the couple in this topic.
Laurie, is a lot of people asking for your program. That's a lot of people interested. But
Yeah, I put the
just to have the last
URL.
comment.
I put the URL in the chat. Yeah, I won't reiterate what Leonardo and Silvina said. This has been such a pleasure, and for me, I think it highlights just the real joy of kind of multidisciplinary approaches and also cross-country approaches. And a lot of the questions, our answer was, well, we don't have research on that. So let this also be a call to action for more research in some of the topic areas that we discussed tonight, and look forward to participating in future events like this in the future. Thank you.
Danielle?
Thank you so much, everybody. I mean, I really have like a pages of notes that I was taking even after reviewing the slides from before. So I always learn a lot every time I get to we interface with international people and, you know, outside urology specialists. So I think it really just highlights how much like, I think that the thing I took away from the most was that, you know, there are a lot of different perspectives on sex, but that focusing on the couple, it's not just about the penis. And I think if patients can have fun with it, I think that's really another great gateway to mindfulness and de-stressing, something that's supposed to be fun.
Thank you so much for everybody. I was enjoying a lot this time and the opportunity to work together with the ISSM, SLAMS, people from around the world. People from different countries talking about a very interesting and that's a challenge to have some conference about this topic. So thank you so much to everybody. Good night, and we're gonna hope that we are going to have a lot of opportunities to make another webinars and opportunities to share about our experience. Thank you so much. Good night, and for the next presentation or webinar.